Good evening. I'm Dr. Jeffrey Spear, current president of the El Paso County Medical Society for 2022. We at the El Paso County Medical Society are very proud of this program. We are certainly grateful for the collaboration of both Star City Studios and KCOS for making this program a reality. We're also incredibly grateful to Ms. Catherine Berg, who has been such a terrific partner for the last 25 years being this program's host. We hope you continue to join us each and every month for this fantastic program, and please enjoy the presentation tonight. Thank you very much.
Fecal incontinence. Yeah, that's what we're going to be speaking about tonight. Thank goodness for PBS, thank goodness for El Paso County Medical Society, and thank goodness for these doctors who don't mind talking about it, and better yet, are very, very excited about giving us information that we need to know. So fecal incontinence, which is also known as bowel incontinence sometimes, is defined as the involuntary leakage of liquid or solid stool. It's a long-term chronic condition, not just every now and again we have an accident. So we're talking about the chronic condition, and its unpredictable symptoms, which can be caused by many conditions. It's also referred to as accidental bowel leakage, anal incontinence, soiling, or lack of bowel control. So you've probably heard those words throughout the years. It's a hard subject to talk about. Patients are often embarrassed to talk about it, but that's why we're here. We're ready to dive into it all and discuss some great new treatments that can make life a little bit easier for those with fecal incontinence. This program is underwritten by the University Medical Center, and we also want to thank the El Paso County Medical Society for bringing this to you now for 26 years. I'm Catherine Berg, and this is the El Paso Physician. Thanks again for joining us. Tonight we have a very unique topic that people talk about. It's not so unique in what happens to people, however. It's a bit embarrassing, which is why we wanted to bring it to you and have 3 doctors really discuss fecal incontinence. It's accidents that happen, but sometimes these are accidents that are chronic, and we're going to talk about treatments regarding this. So I have with me 3 doctors, Dr. Richard McCollum, who is our veteran, gastroenterology, and he calls himself the tummy doc. Thank you for being here. We have also Dr. Vid Fikfak, who is a surgeon specializing in colon and rectal surgeries. And then we have Dr. Nathaniel Ng, who also specializes in colon and rectal surgery. So Dr. McCollum, I'm going to start with you because we have covered a variety of topics, and they're always gross but beautifully explained topics, if I can say that, because we do get very real on this program as people have questions and we want to be very forthcoming with it. So at the end of our digestive cycle, we have to go to the restroom. We have to have a bowel movement. And as we age, sometimes things don't operate the way they should. And so what are we talking about this evening regarding that process?
Well, Catherine, let me first of all say it's great to be back here with you for another year. Happy New Year.
Thank you. You too.
And of course, I regard you as sort of being a doctor, in quotations. You know many, many things about many subjects. It's always a pleasure to work with you. So from the GI point of view, as we know every day, we could have a feeling or an urge that something is moving in our lower intestines, and we call that the urge to go. Many times we're in a situation, driving a car at a meeting, walking around where it's clearly not appropriate to even consider that next step, having a bowel movement. So we are very good at squeezing our muscles in the distal colon and in the proximal, further down in the rectum. Rectum totally is about maybe 20 centimeters total. So at about the rectosigmoid colon area, we start to squeeze. And we're very good at it. In actual fact, some of the best I've seen are airline stewardesses. They can go for hours on international trips, never go to the bathroom. They end up in my office later with constipation.
And teachers.
So we have the ability to squeeze, but sometimes as we age, or we've had some events happening from childbirth onwards, childbirth trauma, we have lost that sensitivity. And by the time we get that warning, we may not have enough time to squeeze and halt the process and prevent losing some of that stool. This is beyond passing gas. This is passing stool into your underwear. And sometimes even at night, waking up with stool in the bed. So this is the next step, either not getting the message early enough, combined with not having a strong squeeze or a strong muscle to hold it. And those combinations lead us to seeing gastroenterologists and surgeons. If we admit it, as you said, this is a silent problem, very embarrassing, and it's oftentimes not admitted to until you have a good relationship and rapport with your patient.
Agreed. And Dr. Fecal, this is a nice transition over to you. First of all, if you can explain to the audience, again, gastroenterology, we've done this a lot, but when you concentrate with your surgeries on colon and rectal surgeries, what does that encompass? And then from there, I'm going to ask you about what percentage of the population actually has this issue, which again, is a transition, is a lot of people don't want to talk about it, they're embarrassed. And maybe it gets to a point where they are almost, what else is there to do but to seek help?
Yes, there's a lot of confusion among patients, a lot of shame, which is unfortunate because it's now a treatable disease. As far as colon and rectal surgery, we literally treat everything that has to do with colon and rectum. So Dr. Ng and I are both board certified colorectal surgeons here in town. And we treat anything from hemorrhoids and perianal abscesses and fistulas to colon cancer. Now, with regards to fecal incontinence and how common it is, we talked before the show about the statistics, and if you look up, you're going to get a range of numbers. But the numbers are actually a lot higher than what you would expect. So I can tell you that about 1 in every 10 patients after age 50 is suffering from this. So if you look at a spectrum of diseases and you put, let's say, diabetes on one side and asthma on the other side, fecal incontinence is going to be right in the middle.
Wow. And like you said, not a lot of people will talk about it.
Correct.
And I think maybe Dr. Ng, this might be a good way to come talk to you. When is it that people, in your experience, actually decide, okay, maybe I should go see someone about this? Maybe it's not just that I can't hold it anymore. When is that 1 in 10 at a point where they're like, okay, maybe I should go, number one, to my internist or go see gastroenterology man, and then surgery comes later. But in your experience, when does that start happening?
Yeah, that's a very good question, Catherine. We see patients on a spectrum like Dr. Fecal mentioned. Those can be patients that are very young. Those can be patients that are very old also. But it comes from a couple things, and I think mainly one of them is embarrassment. They don't want to have this experience that they've had in the past where they had an accident outside, or they had to run home to go change, or there was some sort of result from leakage of some stool in a public environment. And so usually that can be a little bit of an impetus to send them to see a provider. However, you also have the people that have been very long in terms of their chronicity of their disease, and they're just up to that point where they really need some help. And so that's when they give in. And then at that point, go see a provider, and through that, hopefully in the pathway, be referred to somebody that can help them, like us.
Like you guys, exactly. And I know that some of the things that I was reading on today, you've got IBD, IBS, these are some of the, and then you've got chronic colonitis, is that correct, if I'm saying that correctly?
Colitis.
Colitis. So when we're looking at these conditions that people may have throughout their lifetime, that may have been controlled for whatever reason up until their 50s or 60s or whenever this starts being an issue, what are some other types of conditions that people may have that may lead to this? And Dr. McCollum, I'm asking you, sorry, I should have asked you that.
Certainly. So as an internist and a gastroenterologist, I certainly see a lot of diabetes. Diabetes eventually affects the nerves in many parts of the body, and it affects nerves in the gut. So we see a impaired sensation in the rectal tissue. So you don't get that early warning. There's another condition called a connective tissue disease, where, like one is called scleroderma, where, again, you've lost muscle sensitivity and strength. You could have radiation to the rectal area as part of a colon cancer follow-up. that has damaged you. You can have dementia, Parkinson's, and probably just in general, loss of mentation, and that would lead you to have impaired responses to sensation. Patients with irritable bowel syndrome, if they're diarrhea dominant, that diarrhea over time may sneak up on them and they can't react quickly. Colitis, chronic ulcerative colitis, involves the rectum, and sometimes over time it impairs the ability to squeeze your rectum well enough. You may have spinal cord injuries for different reasons, and even become, unfortunately, paraplegic, which is the worst type of incontinence because you can't really protect the area very well over time, a lot of infections. And then, we start off with childhood trauma or trauma at childbirth, where females will have episiotomies or other activities, but interestingly enough, they feel good in their 20s and 30s and 40s, maybe their 50s. We tend to blame them later by saying, you must have had episiotomies. Why is your muscle so weak? But having hysterectomies, having prolapsed bladder surgeries, having any surgery in the pelvis can change the anatomy, which is sort of all held together very nicely by all these structures. When you play with those structures or change them, it opens the gate for that possibility.
Great, because I had 2 episiotomies. That's something I get to look forward to. We'll see.
Not necessarily.
Not necessarily. And thankfully, everything did work out well in that area. So thank goodness for that. Here's the question, because I'm hearing 2 things. I'm hearing some nerve damage or nerve issues, and then I'm also hearing muscle issues. And Dr. Fecal, just because you're the next person to talk to or whoever would like to take this, let's try to separate the 2, or are they always somehow related together? So the nerve, tell the muscles what to do. Could it be a muscle weakness? The nerves are just shot, et cetera. So take that wherever you want, and then feel free to kind of pin in here and there.
Sure. So yes, you're right that the nerves innervate the muscle, and that's where you're getting your muscle contractions from. So they're intimately connected. What Dr. McCollum was referring to with episiotomies is that the muscle is cut, so you have less muscle fibers there to provide that sphincter function, that closing function that people need to control their bowel movements. But a lot of times what we see in patients is that it's not necessarily just the muscle, it's also the nerves that are damaged. I know we haven't talked about this therapy yet, but the nice thing about therapy, the therapy that we're going to talk about, is the fact that it does affect the nerves. It doesn't regrow the muscle, but it has very beneficial effect despite not repairing the muscle.
Well, let's go there. Let's talk about the therapy then, because I know we were talking about Kegels. And in general, what is the first line of defense or the first line of treatment that people come to you and say, okay, well, let's try to strengthen these muscles and or retrain the nervous system? What are some of those types of treatments, I guess?
So there are a couple of things that you can do. You can bulk up the stool using fiber. You can also use certain agents that basically make you a little bit slightly constipated maybe. But the exercises are important. So you have Kegel exercises. You can also get physical therapy with biofeedback where you learn how to use your pelvic floor again.
So explain that. So I hear that and I read about that today.
Right.
Explain what that is. Like what is physiologically happening during the biofeedback portion of this?
Right. So basically what the physiotherapist, a pelvic floor physiotherapist specifically, is training you is exactly which muscle you need to contract. So you're relearning what muscle is where and what signal you're sending to that muscle so that that particular muscle contracts so that you can properly do, first of all, the exercises and then literally relearn what the normal process of emptying your bowels is.
Okay. So, and I guess where I'm getting lost is if it is for most of us just a natural, you have to go, you're done. You don't think twice about it.
Right.
So let's think about a person now that for the last 5 years, things have just not been as smooth. And let's say they're 55 or 60 now. And so for the last 5 years, it's like, yeah, things aren't going well. Are they, or is their body retraining their system? I guess that's my question. How does one get out of the training? And Dr. Ng, I'll let you off the hook for a while. Dr. Ng, you're on the hook now. So how does your body almost untrain itself to where it needs to be retrained from being a very natural type of a function to now it's like, well, it's not so natural, and I have to retrain myself?
Sure, that's a very good question. We don't think about how complex it is when we poop.
Right.
Let's just say,
yeah, it's like you got to go, you go, and you're done for the most part.
Just sit down and then we automatically expect things to happen, which they did at a certain point for patients that suffer from fecal incontinence. When the stool goes down, it hits an area down in the distal rectum where it sends a signal back up to the brain, and it tells the brain, hey, I got something there. And so in order to react, the body naturally usually closes up the sphincter and keeps stuff from coming out. But over time, when the body has been altered by habits, like sitting on a toilet for a long time, for example, and then pushing and straining, and that alters the anatomy that's there that Dr. McCallum and Dr. Fecal mentioned in terms of the nerves. And over time, when the feedback isn't correct, normal, like we would say, when we were born, then that changes how we use the muscles. And in that process, by modifying sort of how the normal process of excreting stool happens, what happens in that situation is that then we start developing bad habits, and then the muscles don't react the way that they should. And over time, chronic damage can occur. That could be one of the reasons for it. And so then lead to, the fecal incontinence that some patients do experience. So process itself does get affected by our habits. So it's not just trauma. One of the things that we talked about, diseases like neuropathies from diabetes and such. So other things can affect it too, including the way that we have caused ourselves to have bowel movements.
No, I think that's fascinating. And when we're talking about biofeedback, is there something inserted into the rectum to see if this type of a movement is good or not so good? Or Dr. McCallum, would you like to take it from there?
Well, I do a lot of biofeedback. Yes, we place a small catheter in the rectum about the size of a coffee stirrer and has a little balloon on the end. And over time, we increase the size of the balloon. Normally, people feel it around 25 to 35 cc's of air. And we ask them to squeeze. And we have a screen there. And we show them, gee, you're not getting into the red color zone, you're in the green or the blue color zone. We want you to continue to learn how to squeeze for me. So I want you to squeeze for the next 20 seconds as tight as you can and see if we can show anything. And then we may have to increase the balloon size so they feel the need to squeeze to stop anything coming down. So it's a trust and a time because it's, a difficult area, a bit embarrassing, but over time, we're relearning. We sort of lost some of that sphincter muscle control, and we're relearning to make it stronger. So it's basically a little catheter in the rectum which has electrodes on it, and the electrodes are connected to our monitor, and the patient learns to try to get squeezing into that red zone and escalate above the blue or the yellow or the green zone. And so it's work in progress. It's never alone.
Right.
We're giving Imodium. We're trying to make them pseudo-constipated, Kegel exercises at home, and we're giving high-fiber diets. And so that's our sort of full-court press.
So I'm going to ask you, for those people who don't know about Kegel exercises, explain and talk one through what Kegel exercises are, just in case there's someone at home that's in the beginning stages of this, and we've mentioned it several times, but we haven't said what it is.
Well, most females in the audience would remember, after childbirth, one of the things your gynecologist is going to tell you is to try to squeeze in your pelvic muscles and sort of restore some strength in the bladder and the vagina and learn to squeeze again and tighten yourself. So every 3 or 4 hours during the day, we ask people to take 10 minutes and sort of isolate themselves and sort of do some push-ups, contract and squeeze, and try to sort of retrain that muscle, sort of lifting weights, trying to get a bit more strength into that muscle. That's really what I take Kegel exercises to be. Perhaps some of our gynecologists go to another level, but that's about as far as I go.
You know, it's funny. I remember after the birth of my second child, I'm 55 and had one child at 30, one at 35. And the doctor said, well, you know, anytime you're driving, and if you're at a red light, that's your signal. Just do your Kegel exercises while you're at the red light. When the green light's going, you're driving, no big deal. But if a red light, it signals that. And for some reason, that's stuck in my head. Because it's something you just do quietly to yourself, and you can be singing along to the radio and taking it from there. Dr. Fecal, I would like to go to you and talk about. So we're going to talk about it in just a moment about InterStim. But over the last, and let's say people who are listening have known my grandma or my mother or my uncle, they've had this issue in the past. What surgically has been the go-to treatment over the last couple of decades? And maybe, and Dr. Ng, I'd like you to kind of chime in on this as well, over the last couple of decades, and what are we leaning into now today as a standard of treatment?
Right. So what we historically did was the workup, I think, was a little bit different. There was a very thorough workup, including an anal ultrasound to assess the muscle, which we talked about earlier. And when we did find a tear in the muscle, there were certain tears that we could be repaired. And the repair that we do is called a sphincteroplasty. It's called that way because the muscle is called a sphincter, and a plasty just means that we repair it. So this is a repair that had very good outcomes. However, after about 5 years, most of these failed. So about 50%, if not more, failed.
Okay.
The other thing that we did talk about, and in some cases it's still an option, but very much an option later on in the process of having fecal incontinence, especially in paralyzed patients, is giving them a diverting ostomy. So people know that as the bag. What it means is we connect a piece of the large intestine to the skin, and the stool goes into the bag. In patients, especially patients who are paralyzed, it's actually a very good solution because they can't really clean themselves, and it provides them a lot of relief because it's a lot easier to take care of. But we hardly ever do that now that we have new therapy.
Okay. And perfect transition, you're a new therapy guy. See, and again, and I feel like sometimes with you two, I'm just going to be asking questions and kind of do the ping pong thing. But when we're talking about new therapy, prior to InterStim, were these the two, again, classic therapies? And again, too, when you're talking about the sphincteroplasty, you're talking about repairing the muscle, and then there's nerve endings there too, right? So I'd imagine that's pretty complicated when you're repairing muscle, but making sure that the nerves are also...
You're not necessarily repairing their nerves. You just repaired the muscle. So instead of, if you imagine that you have a circle that's cut open, you're basically bringing it back together into a circle.
Okay. So the nerve endings they were intact to begin with in that.
Well, they may have been or may not have been. And that is the issue. You're not fixing the nerves. You're just fixing the muscle.
Okay.
It's a very complex neural plexus that's down there.
I bet.
In the anus.
Yeah.
And so the ability to repair that, I think, has been probably one of the bigger challenges that we've had because we haven't been able to do that. Some of the other therapies not showing good durability. There's some injections that bulken the area that have been tried, and there's also some what we call metal sphincters that are magnetically drawn together that have not shown really good results either, and some complications, unfortunately, associated with it.
Interesting. Metal sphincters. Okay.
And so those have been, unfortunately, not successful.
Okay.
And so with the InterStim therapy that we're going to be talking about here, that in itself provides the solution in a way to, it's not perfect, but there is a lot of, I would say, benefit that patients receive from it due to the ability to actually augment the signal. And we're going to talk about that here in a little bit. I don't want to jump too far ahead. To help with getting the information back to the brain, and then also allowing the brain to send the signal back down to the muscle. So sort of covering two bases all at once. And so that's, I think, one of the big benefits that this technology offers.
I agree. And Dr. McCollum, I know we met for quite a bit prior to the program starting. And if you can explain, just re-explain everything that you explained to me when I walked in, because I just thought it was fascinating of sometimes I think that you called it just very little lead time. And that made sense to me. It's like sometimes your body is ready to let things go, but you don't feel what's happening. And so you don't have a lot of lead time, so you don't get to the bathroom on time. And so this kind of helps with helping your body feel a little bit of lead time. And what I thought was interesting too is the juncture of where the sigmoid colon and the rectum come together. That's kind of where you were talking about this balloon. So explain to the audience that sensation that we feel when everything's okay, and the sensations that we're not feeling in time when things aren't okay.
Well, the theory that the InterStem tapped into is the fact that the distal sigmoid colon and rectum area are involved with somatic and autonomic nerves. They're kind of big names for the audience to think about, but these are so-called your internal nervous system coming from the spine, activating sensation in the distal rectum. Sometimes the pudendal nerve is used as a generic marker, but we're talking somatic in that case, or spinal, as in the case of paralysis or injury to the spinal cord. And these all combine to sort of keep you primed up and ready to experience that sensation and react to it by squeezing your muscle, assuming it's intact. And most times it is. So if you don't get the signal too late, because those nerves are somewhat impaired, your squeeze is not going to be probably enough or on time. But generally we see a combination that there's been some injury also to the muscle over time, and your maximal capacity is not there, as well as you don't get the warning that early. So we're trying to spiff up your distal nervous system and see if we can sort of upgrade it and return you to somewhat of a normal response to that sensation, that distension of your rectum, that urge. Try to make it felt quicker, and then you have time to squeeze better. So that's what we're trying to restore by stimulating what's called the sacral nerve,
Right.
that the surgeons will go into more detail with. But it's been shown, in actual fact, that after years of using this, your muscles are not reborn. It mainly activates your sensation. You get your rectal sensation process is much better. It doesn't make your muscle strong. You're not doing weightlifting with this stimulator. You're improving the process of feeling it quicker. And then over time, with other exercises, your muscle is able to kick in and be stronger. So the episodes of incontinence go down each week over time.
So on that note, between Dr. Fickfack and Dr. Ng, who wants to start with how this is implanted, for the lack of a better word? Dr. Fickfack, since you're on my side, and again, we'll kind of do the ping pong thing again, but when you are performing this kind of a surgery, implanting, and you were talking about that there is an implant in there, and then also there is a control mechanism on the outside. So maybe we'll talk with Dr. Ng about the control mechanism and then the implantation with you. And again, feel free to bounce back and forth on that.
Sure. So I think it's important to understand that actually the entire process involves two separate procedures.
Okay.
So the first procedure are actually test electrodes. So you don't get an implant that would be a permanent implant.
Okay.
What we do is we put the patient prone, meaning that they're lying on their belly, and then we identified based on anatomic landmarks the exact spot where the needle needs to go into the S3 foramen. Basically, if you look at the sacrum, it has little openings, and out of those openings come sacral nerves. We're trying to stimulate the nerve, so we have to get next to the nerve with the electrode. So the first part of the procedure is really just placing the electrodes on both sides, and then testing them if they work. And we can see that pretty quickly because we connect it to a stimulator that is an external machine, and Dr. Eng will talk about that. But we can see that, we are in fact stimulating the correct nerve. If that treatment works, then we can move on to the second portion in about 1 or 2 weeks, which is exchanging those leads for a permanent lead that connects to a battery.
Okay.
So during the first procedure, all the electric leads are on the outside, and there's a little machine that patients can control with their cell phone. But during the second part, everything is hidden underneath the skin. And that is where we're talking about you have a battery in place that'll last for about 15 years, and it'll
That's
do
amazing.
its job, right? Yeah.
That's amazing. And to piggyback on that, before we go to the external portion of it, so thank you for explaining that there is this test period. During this test period, when Dr. Fickfack said, we wait to see if it works or see how it works, what are you all studying in those 2 weeks? Is it a daily feedback? We were talking about biofeedback earlier. Is it a daily feedback that somehow gets transmitted to you all, or does the patient write it down? Like, how do you know if it's working and if you need to up the stimulation or bring it down, et cetera?
In reference to determining progress, it's a combined effort
Okay.
between both the patient keeping a log and seeing when they have the sensation they need to void and whether or not they actually have an accident. And then also there's data that goes back into the external component that sits there during the test period and sends the information to the company that will allow them to make some alterations if necessary. And so there's a very close interaction between both the patient and also Medtronic, which is the manufacturer of this machine. And through that, they're able to make changes during that test period also, and then see whether or not those changes translate into real world effects. And then during that, be able to see whether or not patients actually experience improved fecal continence. And so the number that we're looking for basically is 50% improvement during those
nice.
2 weeks. So
Okay.
if you had 4 accidents before we implanted it, and this is just an example number, you only have 2 after we've implanted it, then that's going to be a sign of success. But if they're not having that success, there's still room for modification during that test period to see whether or not we can achieve that number in order to prove efficacy.
And that's such a game changer. I mean, there's a chart that we'll show later that Dr. McCollum and I were looking at prior to. It's like once that is implanted from, what was your chart? Saying something like, there was like 16 times. So somebody would have accidents 16 times a day and it would go to about 1.8 times a day. And so again, a day. That's a lot to go during the day. But 16 times a week and then going down to about 1.8 times a week of having an accident's wrong, but leakage or fecal incontinence. So that to me is huge when it comes to quality of life. So now let's take it to, and I'm switching back and forth again. Now let's take it to this device that we have outside that is only during the interim, these couple of weeks that we're trying to find the right sweet spot. Is that correct? And so it's almost like a pacemaker, I understand. So once you're ready for the permanent implant or for the permanent electrode, where is that implanted? Just kind of talk about, say it's in there for 2 or 3 years and they're having bigger problems. Can it go back and be adjusted, et cetera, et cetera?
Right. So, as far as the first portion of the procedure we just talked about, just placing the electrodes, this is probably one of the only treatments where you can test it before you actually decide that you're going to do a permanent implant, which is really nice to have. It's not like you can do surgery on somebody and they put something back.
Right.
So it gives us a lot of information. Medtronic as a company has been doing this for a very long time. And we have a good relationship with them. I always say that this is a sort of a multidisciplinary approach between gastroenterology, colorectal surgery, and the company, which is Medtronic, and the representative, Mr. Pinedale. So the importance of that is that everybody has their role. So we work up the patient, we treat them, but they also have a diary. So going back to how do you know that they're better? Basically, they keep a diary before they see us, after we make the changes that are conservative management. And then after they have the implant, they also have a diary. And so we can actually see those numbers very clearly if they're getting better or not. So as far as, the little device that's on the outside, they have on their cell phone, they can adjust things. They have a direct contact with the
Perfect.
with the rep from the company, and they're in constant contact with them. They can call them at any point in time, and they usually call them with very impressive stories, like, I haven't had a accident for like this entire day, and this is the day after the implant was placed.
Oh my. Okay.
So all of those adjustments can take place. Now, if let's say that you do have an implant with the battery and everything, and there are problems down the road, you always check the battery first, just like with everything else.
Right. Plug it in, turn it on and off. Right.
But there are always things that we can do. If the system completely fails, we can go to the other side and try to implant it there. But it's just in most patients, I will say that the implants are very effective, and you'll see that after 5 years, in most patients, they still work.
So here's my question, just again, physiologically. So we've got the implant. Is this then, you're talking about 10 or 15 years, is this then a forever treatment for that person? And let's say they got it when they were 50 and now they're 65. Would they, and again, who am I to say 15 years in the future what our research will hold? But is there any physiological retraining that's happening within the body, or this really is going to be an external stimulation going forward to help those nerves realize it's time? And Dr. McCallum, I see you nodding your head. So,
Well, we've done, and others did, but during this double-blind trial with the FDA, it was double-blind, turned on, turned off, we found that after a year or two, your sensitivity was better. You could feel a lower threshold than you did before you were stimulated. So I don't think we've endorsed stopping your stimulator just based on that, because even 1 or 2 accidents now and again, a week or a month, is still a few
it's
too
still
many.
a lot. Right, absolutely.
So I think we do overkill if we can keep it going. And then the good thing is these patients have an interrogator. They have a wand where it's in the buttocks, the pulse generator, the battery, and you can upgrade or increase the strength of your current any day. How do you know you're doing that? Well, the biggest way of knowing is that your big toe begins to twitch and tingle. That implies that you have hit the sweet spot here. You've increased the voltage current, and it's going to be transmitted to your rectum. It's also transmitted to your big toe. So you can back off a bit. But the patients can work with and find the right spectrum as well. But I don't think in general we try to encourage going without it. There may be a few people, as I said, diabetics, where there's probably a 1 or 2% incidence over time where your pulse generator pocket in the buttocks, by trauma or bad luck, could get infected.
Gotcha.
And that may have to be replaced. But this is a pretty protected area compared even to the cardiac pacemaker, which is more vulnerable. This is pretty well hidden down here in the buttocks. And the life is, the long-term life expectation is very good.
And it's so fantastic that the patient is able to control it themselves and increase stimulation or decrease stimulation.
They can.
And have you found that through the years, I think you may have answered this already, but I just want to make sure I'm clear on it, that through the years, it's sometimes a stimulation that you have found thus far, and again, this is relatively new, last decade or so, after a couple of years of stimulation that they need becomes less and less for the most part. Is that what I'm hearing? That the stimulation that they are providing for themselves, that they can provide more stimulation or less stimulation, that through the years they're finding that they don't need as much stimulation as when they first put it in?
I think that's probably true,
Okay.
Catherine, because they are also continuing, the Imodium maybe intermittently, fiber, we're doing everything at the same time. We're not just saying take the stimulator and good luck.
Right.
There's still significant medical therapy accompanying our surgical colleagues.
And you talked about follow-up. For the most part, these patients are followed every 6 months, every year. Is that correct?
That's right.
Okay, perfect. So I don't want to get off topic, but I love giving happiness to the audience. But there is bladder incontinence, which in and of itself, especially in females, and we talked about this earlier, can be a very different game. And I get it, mainly childbearing issues. But this is kind of in the research / checking out stages of helping out with bladder incontinence too. And I'll start with Dr. McCollum and then feel free to chime in.
Well, our surgeons will definitely know this. Now, it's been well established in females that we can help urinary incontinence with this procedure. And we have a urologist, gynecologist at UMC, Texas Tech, who is already doing this procedure. Most of our patients, it's dominated by fecal. Even though they are female, it's dominated by fecal. But there's a sprinkling of urinary incontinence, and the parameters that are used with this pulse generator are not much different. Whether you maybe turn it up, a few more volts for the urine, etc. We often can combine a bit of urinary incontinence with fecal incontinence, but there are women mainly, obviously, who have only bladder incontinence, urinary incontinence, and we have a program for those patients too. We have a surgeon who's more in the GYN world who does that specific, same procedure, same theory with those patients. But our surgeons may want to add some more comments.
Yes, please. Anything you want to? Dr. Fickback is nodding to Dr. Ng. So Dr. Ng, you get to go. That's what I get to see behind the scenes that the audience doesn't get to see. I kind of love that. So Dr. Ng, is there anything you'd like to add to that?
I think Dr. McCallum hit it on the head, very accurately in reference to the use of the NurseStim technology. It does apply to bladder incontinence also. Implantation, again, is pretty much the same. But it does have that benefit. And a lot of times when patients get it for example, bladder or urinary incontinence, they'll find a difference in their fecal incontinence also just by default. So there is that benefit that's out there, the crossover that exists between the two.
Nice. Dr. Fickback?
There's a significant overlap. So, just talking to the urogynecologist, they see a lot of patients with fecal incontinence because they're originally seeing them for urinary incontinence.
Ah, okay.
The beauty, just like everybody said, is that you implant this, it provides relief of both. So, it's like one shot, 2 pills. Yeah.
One shot, 2 kills. I like that. We're kind of at a time where I want to stop with my questions for a little bit because there's so many things that we can talk about with this. So Dr. McCollum, because you are the veteran on the board, is there anything that we have not discussed yet that we'd like to get into? We still have a good amount of time, a good 15 minutes left. But I always feel like there's something that you were driving over here and I hope that she hits this and I hope she hits that.
I want to make sure we give the message to our audience that they're in very good hands. I run a program already called the gastric stimulator or the gastric pacemaker. We put in the most gastric pacemakers in the world with our general surgery department. And so we have national reputation for that. Luckily, we now have some great surgeons in the colorectal world that can expand their expertise to doing for doing stimulation of the sacral nerve and treating fecal incontinence. But public listening should be very encouraged that they're going to be in the hands of experts who have been doing this. This is not something we're doing to just jump on the bandwagon. We initiated many of these early ideas about stimulation of the gut, and we are continuing to have a total program. We measure all the rectal parameters, and we follow patients. We're probably the only program, certainly in Texas, that has a fully integrated surgery GI relationship, and where the GI department in particular has had a long experience with stimulating the gut. And so they can be rest assured that they're in very good hands.
So if you don't mind, what does that mean when you are stimulating the gut, pacemaker for the gut, for gastric pacemaker? What are the problems that resulted in needing a gastric pacemaker, and what is this gastric pacemaker doing physiologically in the gut? Like, what is it making the gut do?
Yeah, well, that's why we try to minimize the word pacemaker. Unlike the heart, we're not awakening your muscle and making it reborn. What we've learned sometimes the hard way is when I give you a gastric pacemaker, you come to me with nausea and vomiting and diabetes and other reasons. I'm mainly blocking your nausea. This stimulator goes up nerves to your brain, and in the chemoreceptor trigger zone, which is the area of the nausea and vomiting center, I'm stopping your nausea. It's the best antiemetic we have. And therefore, soon after that, your stomach feels better. But the 1-2 punch we offer now with Dr. Brian Davis, which is new in this country, is we're cutting the end of your stomach, called the pylorus, to make sure the slow emptying process where the food sits there from the diabetic injury, it's open, food goes out. But we stop the nausea and we stop the vomiting, but we add the bonus that you will empty your stomach and you can go back to eating fairly normally. So it's been a learning curve. And we found out that this is the best approach, pacemaker or stimulator plus cutting the muscle called the pylorus. So it's a little more distance. We have a stomach and a small bowel, and we have to try to maintain nutrition. So we have a little more of a charge on our hands.
So you were talking about diabetes specifically, and I feel like this is such a simplistic question.
Yeah.
But in general, what causes nausea? What is it that, and I'll get nauseous maybe 10 times a year for whatever reason, but what is it that causes nausea? I know when I was pregnant, I needed to make sure that I ate before I went to bed so I wasn't nauseated in the morning. I guess there's, stuff being in the stomach, et cetera. And I know I'm sure a plethora of reasons people get nauseous, but what is it?
Well, probably the commonest cause in the world is pregnancy. So, you've got these progesterone receptors up in what's called the chemoreceptor trigger zone. You're given opiates or narcotics post-operatively or other times, often makes you vomit. And then your stomach can be distended and stretched, and you activate vagal nerves and other fibers that go to the brain and say, gee, I'm not doing well, I'm hypersalivating, I'm sweating, I'm going to vomit. And so serotonin, you're basically activating receptors in the brain by stimulating, parts of the gut. I'm distended here, I'm distended maybe during pregnancy, or I'm just progesterone sensitive. Not all pregnancies are the same, but many end up with vomiting from releasing more estrogen and progesterone during the early parts of pregnancy. So these are receptors in your brain which are sensitive to external events, chemotherapy. You can activate them and arouse them very quickly. Seasickness, all these things, you will meet a very friendly receptor who will be glad to vomit.
That's so interesting. I've always wondered that because, I'm a motion sickness girl. Yes, I threw up like crazy when I was pregnant. I'm one of those girls. And it's like, what's happening to me? But that's the first time I've heard it put into the thought process of just different nerves that are talking to a portion of the stomach.
And just distension. As surgeons know, when the bowel's obstructed, you're very distended. Pain, even severe pain. You break your leg.
Right.
Skiing or something. You're going to vomit, not because something's going on, in the brain necessarily, except the pain is so severe, one release is to activate these receptors, and I'm going to vomit.
Right.
So the brain, tries to handle things, but it ends up with limited options. One is eventually I have to vomit.
Or a hangover. Goodness gracious, I had one of those once. Dear Lord. Dr. Fecal, let's go to anything that we have not talked about that you thought would be important to talk about tonight before we wrap up. And if there's nothing, there's nothing, but I always feel like there's something.
Right. So I think it's important, like Dr. McCollum said, for people to understand that there are treatment options that are available now that weren't available before. We've actually set this up as an entire program. It's a multidisciplinary program, meaning that Dr. Ng, Dr. McCollum, and I are work together with the company. And we've actually started reaching out to patients. So not only are we trying to identify new patients with fecal incontinence, and we've had lecturers around town to different practices and delivered the fecal incontinence questionnaire for screening. But we've also looked at databases from Texas Tech and University Medical Center to identify the patients who already have the diagnosis of fecal incontinence. And there are tens of thousands of patients with that diagnosis.
Wow, tens and thousands.
So we're trying to reach out to those patients because we want to make them aware that this treatment is available. And if they're experiencing these symptoms, there is absolutely, first of all, they need to know that somebody else is suffering from the same problem. I mean, that's half of the burden right there. But then there's a solution. And we want to make them aware that there is a solution, that we're here to provide that treatment. And we're going to do it in a very intricate, multidisciplinary way, where they're going to be seeing us, and we're going to do the appropriate studies and the appropriate workup that they need and administer the right treatment.
Nice. And it's nice too, I think you hit it on the head when again, this is an embarrassing issue. Not a lot of people are going to talk about it. They're not going to bring it up unless it's in a medical setting. So Dr. Ng, I would love for you to talk about whatever we haven't brought up yet, but I appreciate the fact that the show is a topic, because this is not a topic that I think I've ever done on this program before. And I like embarrassing topics because nobody else talks about them. And I feel like, oh, that's the stuff that people are going to remember. So you're going to be remembered. People are going to go like, hey, I saw you and I heard you, and they're going to remember you. And this is a great topic to remember because everyone's got an issue now and again. I've had diarrhea. Should I say it out loud? I've had diarrhea. I've actually had an accident before. And I was talking to Dr. McCollum that I want to make sure that we get across that what we're speaking about tonight is a chronic issue, a treatment for a chronic issue, not when and Dr. McCollum, you were funny. It's like I went on vacation, had some bad water for a week, and my stomach's not doing well. I have diarrhea for a week. I've had some accidents that week. This is not what we're talking about. No. This is more of a chronic issue. So that's something I meant to say, 15 minutes ago, and I didn't. But Dr. Ng, is there anything that we haven't touched base on yet that you'd like to talk about?
I think we covered, excuse me, I think we've covered a lot already this evening. For those patients that have had the Medtronic stimulator placed, the InterStim, I mean, it's just like colonoscopies. If you don't talk about it, then your friends don't understand what it means to have that benefit of knowing that all your polyps got removed, and you got cancer prevented. And so I think that those patients that do have InterStim already placed, could be a little bit more verbal in sharing with their friends and seeing whether or not they have similar situations, or at least talking about the benefits of it. I think that takes away a lot of the taboo away from it. In terms of the stimulator itself, it's really not that big. That's one of the things that I just thought about. People say, you put it in my buttocks, am I going to sit on it this entire time, even though I can hold my poop in? But it actually sits a little higher up, right above actually our bone, that hip bone, and the fat that's there. And so it's the approximate location, so it's really comfortable, like Dr. McCallum had said. So I just wanted to sort of clarify that out there to make it so that patients have a better understanding of where this implantation is going to exist after it gets placed.
That makes all the sense in the world, because you want to make sure, again, that it's something it's comfortable. I know this is not in any way an oncology show, but because we have this discipline here, and you talked about cancer, I just am always a proponent of saying, hey, let's get your screenings, right? So Dr. McCollum, I'm going to let you take it away from, because we have a little bit of extra time, which is really nice. We rarely do. We're always like right at that moment. But fecal incontinence doesn't really have any symptoms, or colon cancer usually doesn't have any symptoms. Let's throw that screening situation in there.
Yeah, well, see, we're down to 45 years of age now because of knowledge of how prevalent colon cancer is. And we know, if you look in the paper, that it's never over. Pele, one of the great soccer players of all time, just died of colon cancer. And, he was in his 80s. So we are going down possibly into our 40s. We ain't going down to 47 because there are still many cases of missed cancer or cancer that has evolved before age 45. So, yes, breast and colon, if you can attack those aggressively with your family, please have them screened and please take it seriously because no one is spared and you won't escape.
And Dr. Ng, you said it really well too when you were making this part of a normal conversation. I feel like colon cancer and colonoscopies, for the most part, are kind of becoming or have become part of a normal conversation. And again, at 50, but I'm glad you're saying 40s now.
Yeah.
At 50, I just feel like women know to get their mammograms, guys know to get their prostates checked, and then 50 comes the colonoscopy. So we're looking at maybe 45 to 40 years of age being the case. And the nice thing about that is you get your colonoscopy, and if you're clean and good, you're fine for about 5 years. And please correct me if I'm wrong.
5 to 10.
5 to 10.
Yeah.
But if there is a polyp, what happens, Dr. McCollum?
Well, we're going to bring it down closer to 3 to 5, and then we may have to throw in a family history. But we have all these little check boxes to try to make sure we keep a pretty close tab on you.
Exactly. And if there is a polyp in there, or 2 polyps or 3 polyps, the colonoscopy will take those polyps out. And so they're done, they're gone. And so that chance of having that polyp turn into a cancer is no longer a chance of turning into a cancer because of the colonoscopy. So I just thought I'd throw that in there. I want to say thank you so much, Dr. McCollum. Again, you always bring the most interesting shows this way. So thank you so much for that. Dr. Vid Fikfak and Dr. Nathaniel Ng, thank you so much for being here. The surgery part's always the gross part, but very fascinating to me. And UMC for underwriting this program. And a big thank you always to the El Paso County Medical Society, who has been doing this show again for 26 years. And if you didn't catch all of this, you are welcome to go to pbselpaso.org. You will find this show and all kinds of programs on there. Just either search for topic or just look for the El Paso Physician on there. You can do that with the El Paso County Medical Society website, which is epcms.com. Or you can go to YouTube. So you can go to YouTube and look up the El Paso Physician, and from there, there'll be a piggyback of different programs that you can kind of spotlight. It's like if I have heart issues or if you want to talk about fecal incontinence. So if you only caught part of this program, there are the 3 places that you can go to find it. So other than that, I thank you guys for being here. Happy New Year. Yes, go ahead.
Catherine, let's give a real shout out to Patsy Slaughter.
Oh, yeah.
Who, like you, has been a major player in educating us in El Paso, runs the County Medical Society so efficiently and so quietly in the background. And Patsy, you've done a great job. We all love you. And
I'm on the phone with her all the time. I can't do anything without Patsy and Elsa.
Appreciate you, Catherine.
They have us going all the time.
We appreciate you, Catherine. You've made a major difference in El Paso as far as medical education.
Thank you, sir. With that, you've been watching the El Paso Physician. I'm Catherine Berg. Good evening. Could you tell I was staring at that clock? Thank you for turning it off. I was like, oh my God, this has been the longest 2.5 minutes of my life.